Okay, so good afternoon and hello again. So as you can see from my title slide, you probably guessed my position on this already. So the question before us this afternoon is remission induction first or straight to transplant for early AML relapse and MDS. And there's a bit of a mixture in the data there between those two groupings, but we'll consider them hopefully logically. So I think replacing the question mark with an exclamation mark and crossing out the first part of the question, that gives the answer. Straight to transplant in early AML relapse MDS. That's my position, and let's see if I can defend it. I'm a transplanter. I like transplanting patients. I like transplanting patients when they can benefit it from the most, when they aren't too beaten up by the previous chemotherapy they've received, and when their disease is in a state that they can actually benefit from all of the good things that transplantation brings with it. I have to acknowledge, though, that whilst some patients do indeed benefit from transplantation, some don't, either because it doesn't add anything to their outcome over conventional therapy, such as shown in this paper from the New England Journal of Medicine a few years ago, but in some instances, for instance, those patients who have got FLT3-ITD, there's clearly a benefit for having a transplant. But I have to acknowledge that there are some situations where transplantation struggles to show a benefit, and here's a good example of that. I'm not going to really go into the details of this too much, but those patients who have, in this very recent analysis, monosomy karyotype, who do not attain a CR with remission induction therapy, really have a dismal outcome no matter whether you transplant them or not. And it's debatable, and we're not going to debate it today, whether that particular karyotypic abnormality or cluster of karyotypic abnormalities can be rescued with allogeneic transplantation at all. Professor Champlin made this point too, that with respect to secondary AML or treatment-related AML, we can't hide behind the usual stratification of favourable or unfavourable cytogenetics, that those patients tend to do universally badly and need to be considered to have life-saving therapy such as transplantation without waiting and seeing what's going to happen next. So here's de novo AML with the three-way stratification between favourable, intermediate, and unfavourable cytogenetics, whereas all three groups perform quite badly when you're thinking about treatment-related AML. So I think before we get on and consider the question in any depth, I think that we have to think about what we're actually asking. So what does progressive MDS and early relapse AML actually mean in the papers that are out there in the data when we're trying to analyse it? And it can mean different things to different people. And you can see this is really just some thoughts that I've put down on the slide here, but we may have a number of variables. We may have disease kinetic variables, we may have disease sensitivity variables, we may have patient tolerance variables. So any patient who has progressive MDS might be somebody who has a slow progression, such as Professor Champlin showed in some of his slides, or patients who have very rapidly, essentially leukemic progression soon after diagnosis. And then when we think about relapsed AML, it may be those patients who have late relapses after a sustained period of remission, or those patients who essentially have refractory disease and very early relapse despite a transient apparent morphological remission. And these patients clearly, you know, I know, behave very differently around transplantation. What about disease sensitivity variables? Well, we may have patients who truly have primary induction failure. They show complete chemo-refractoriness, and that is a particular group that, of course, is extreme concern, and we're going to consider those a bit later on. And then there may be those patients who attempt reinduction chemotherapy and that is successful, although, as you well know, attaining a second remission is much less guaranteed than attaining a first remission, and that worsens with increasingly poor cytogenetic subgroupings. So then we may be considering patients who are actually transplanted in CR2 versus those where reinduction chemotherapy is attempted but has failed, so those patients have insensitive relapse, or alternatively, and I'll show you some data about this, patients where reinduction chemotherapy was not attempted at all. So you don't know what their sensitivity to chemotherapy may be. And then we have to balance up all of those patient tolerance variables, such as cumulative toxicity from re-exposure to remission induction chemotherapy, which may compound coexisting comorbidities, particularly in the older patients, which are often already very challenging AML patients because of their biology. I'm not going to dwell on this slide too much, but really just to point out, this is some unpublished data from our unit, and Professor Champlin has already made this point, that those patients who are transplanted beyond CR1 can meaningfully benefit from allogeneic stem cell transplantation, less uniformly than those patients transplanted in CR1, that is true, but nonetheless it is still appropriate therapy, and that the type of transplant that's undertaken doesn't seem to necessarily matter with respect to disease control because of the advent of the graft versus tumour effect through the allogeneic engrafting immune system. So that despite these patients being treated with reduced intensity transplantation, in our unit much the same as MD Anderson uses either fludarabine melphalan or fludarabine busulfan, and these patients are often overrepresented with both respect to older patients and more likely to have an unrelated donor, their outcome is comparable to those receiving myeloablative conditioning. So the question of transplantation and untreated relapse is not one that is brand new. It's not one of the 21st century. And here is some data that was initially published back in 1983. So getting a little old, but 20 years or maybe no, so 30 years old. But I think the important thing here is that there's a small number of patients in this report, and it was followed up with a much more substantial number, and there's the two references there, much more substantial number in 1992, but I think that the number I want you to remember is around about 30%. So these patients, whether they were this original 17 or the more expanded population of 126 transplanted and untreated first relapse, 3-year disease-free survival, about 30%. Professor Champlin and I and many other people in the room like transplanting AML because it does actually save a proportion of patients, not as many as we would like. But again, if we go back to this publication back in 1995, which was utilising a very intensive conditioning regimen, again we see that around about 30% of patients with acute myeloid leukemia and untreated first relapse had a plateau, were able to have a sustained remission following allogeneic transplantation, and for reasons that have gone into before with other speakers, and I'm not going to dwell on today, that seemed to be largely mediated by the presence of an allo-responsive T-cell compartment, here the surrogate marker of which demonstrated by better disease control in those patients who had graft versus host disease, which roughly equates to the graft versus leukemia effect. So the real question, I suppose, before us is that, yes, we can transplant patients in untreated relapse or who have advancing progressive MDS. Seems to be a benefit in approximately 30% of patients. And you've already seen some of this data, or at least similar data presented by others, that the outcome depends on what type of MDS you're talking about, on the karyotype of the underlying disease. And then if we consider these two bottom curves here, which is should we actually give remission induction chemotherapy beforehand, you can see here that the patients who have not received chemotherapy before their transplant have, in this analysis, have actually done better than those patients who received remission induction chemotherapy ahead of time. If we actually, and here again, if we look at the outcome of the chemotherapy, those that achieved a complete remission after chemotherapy did as well as those patients who received no chemotherapy. And of course, as you might suspect, the patients who had no response after remission chemotherapy did the least well out of everybody. But really the take-home message from these analyses is that you don't require reinduction chemotherapy in myelodysplastic syndrome in order to benefit from allogeneic stem cell transplantation. Remember, I asked you to remember that 30% number. Well, here is a prospective analysis of patients who were treated with a combination of intensive chemotherapy for reinduction, followed by either allogeneic or autologous stem cell transplantation. And for the purposes of clarity, I'm not going to talk about autologous stem cell transplantation today. This is the survival curve for those patients who received an allogeneic HLA identical sibling donor transplant, and you can see that with a programmatic approach with intensive chemotherapy followed by sibling allogeneic stem cell transplantation, the outcome was 30%, much the same as we've seen in the untreated, in those patients who were transplanted in untreated relapse. So it doesn't really seem to matter whether you give reinduction chemotherapy to the majority of the patients, the outcome post-transplant seems to be the same. Here's another analysis, and really pretty much shows the same thing, that if we look at either the non-relapse mortality, these aren't statistically different, these curves, but the patients who had no induction or induction chemotherapy did much the same with respect to their tolerance of transplantation, and the relapse-free survival was actually better in those patients who had no induction chemotherapy. One of the things that's very important, and I talk to my patients a lot about this, and Dr. Champlin raised this as an issue, is the timing of transplantation. That if we wait for the writing to be well and truly on the wall might well and truly fall over on top of our patient. And so that patients who are transplanted early on with respect to the HLA identical transplantation for patients with myelodysplasia do considerably better than those patients who have delayed time to transplant. Now, some of that delay is because of exposure to reinduction chemotherapy, and some of that is for other practical reasons, such as the timing of transplantation, the donor availability, and so on. But our really take-home message today is that getting your patient with myelodysplastic syndrome to an early transplant is associated with a significant improvement in outcome. Dr. Champlin showed his own data regarding age, and it's very encouraging as we all get a little older that the outcomes are much the same no matter what age you have. But in this analysis here, patients who were greater than 40 were overrepresented with a higher rate of non-relapse mortality in that same analysis. This is the same paper as I've shown here. In transplantation and remission, there are papers out there that suggest that if you can get your patient to remission prior to allogeneic transplantation, that they do better. And here we have the survival analysis from that paper. This is a pretty respectable survival curve, around about 45% in patients who respond to remission induction chemotherapy prior to transplant. And this is my own annotation in this box here. What does that actually mean, that those patients get to transplant? Well, first of all, that they were fit for induction chemotherapy in the first place, that they responded to induction chemotherapy, that they maintained that response until such time as they got to bone marrow transplantation, and that they remained fit enough, well enough to actually proceed with transplantation. So this is a highly selected group of perhaps better players with more responsive disease. So these are some of my conclusions. Most MDS or relapse AML patients do not benefit from induction chemotherapy prior to allogeneic stem cell transplantation, and is it possible to identify patients who might? And unfortunately, in the setting of myelodysplasia, that's not clear, but here's an article from last year, Charlie Craddock's group, which really identified a number of important points, some of which we've covered already, predicting the outcome from unrelated donor stem cell transplant in patients with very high risk AML, that is the primary refractory AML. And really, just to quickly go through this, that time to transplant was very important, that not poisoning your patient with excessive induction courses of chemotherapy was very important, and that patients who had lower than the median blast numbers in their bone marrow did better, as you would suspect, than those patients who had rapidly progressive high bulk disease. And that's just the survival curves based on those two of those three, and whether the patients had CMV negative serology, the outcomes being very good or very acceptable for those patients with none of those risk factors, and much poorer for those patients who had all three. Professor Champlin touched on this point. Is induction chemotherapy of the old Aracy-based type a Stone Age approach? And I think it may be coming so, particularly in patients with myelodysplasia. There's a paper just published this year looking at pre-transplant therapy with azacitidine compared to induction chemotherapy followed by transplantation in patients with myelodysplasia. And the take-home message is shown here on the second bullet point, that in the patients who received azacitidine as opposed to induction chemotherapy, their overall survival at 1 year was approximately doubled. And importantly, not only was the disease control better, but their non-relapse mortality was also improved, presumably because patients arrive at transplantation with less cumulative toxicity. So in conclusion, remission induction chemotherapy is not necessary for control of relapse in early relapsed AML or myelodysplasia. A delay in delivering induction chemotherapy and the cumulative toxicity may detrimentally affect post-transplant, that is, the delay that is caused by the delivering of induction chemotherapy. I think some of the data out there is heavily influenced by selection bias, and that those patients who can tolerate induction chemotherapy are overrepresented in those better survival curves. And then non-conventional disease modifiers may improve post-stem cell transplant outcome, and I think that there is significant benefit to be had from patients having pre and, as you've seen from Professor Champlin, post-azacitidine, post-transplant azacitidine. I was very impressed by Swami's smiling faces at the end of his presentation, so I added a couple of my own, and these are true photographs taken either from a bone marrow biopsy or a cell in culture. That this one's smiling, this one doesn't look so well. But thank you for your time.